commonly used sleep medications, because often inability to sleep is related to patients being anxious.
Well, give us a sleep medicine maybe everybody here can relate to. What would you think of maybe an Ambien?
Okay, I'm familiar with it. I don't use it or have any experience with it, but...
Would Ambien cause a reduction in anxiolysis?
Well, it would possibly cause, in anxious patients, a reduction in their level of anxiety, yes.
Now, when you use a drug to reduce the anxiolysis for purposes of producing sleep, there's different degrees of sedation, isn't there?
Yes, as we discussed, the degree of sedation would depend on the dose, various individual factors. Patients that would take an Ambien or multiple Ambiens every night would have less of a response than someone like me who's never been exposed to it. Would take one Ambien, I might sleep for 12 hours, I don't know.
Now, say a person did take an Ambien or lorazepam or some midazolam. Is there a concept that describes the sedation as subject to verbal stimulus?
Well, if you look on this ASA chart, which I would also point out, it was approved initially in 2004, but it was actually amended in 2009, so it's fairly recent. Yes, minimal sedation, which also includes anxiolysis, so this is the one end of the continuum that we've been talking about throughout this trial. Responsiveness is normal response to verbal stimulation, so that a patient could be resting quietly in a sleep state, but they would respond to verbal stimulation.
So if I took an Ambien to go to sleep and I actually fell asleep on the Ambien, you would expect to be able to come into the room and call my name and I'd wake up?
Under normal circumstances, unless you took a massive amount or you were extremely sensitive, then it may take me shaking you a little bit or calling your name very loudly.
Okay. In the event that you gave a slow bolus of propofol, say 25 milligrams over 3 to 5 minutes, would you also expect to be able to wake up the patient by verbal stimulation?
Certainly, giving that dose over 3 to 5 minutes, I would expect a patient to be in a very light state of sleep, if they're even sleepy at all. The studies that our group and others have done have found that in these very low doses, you can demonstrate reduction in anxiety scores, but they don't produce amnesia or lack of recall and generally do not produce sleep. It could, in a patient who's very tired, though, produce a light, restful state.
We've had doctors testify in this case that the slow injection of 25 milligrams over 3 to 5 minutes, I think it was Rochelle Cooper, Dr. Rochelle Cooper from UCLA, indicate she's not sure that a person would go to sleep on a 3 to 5 minute injection of 25 milligrams of propofol. Would you agree with that?
Yes, I would.
And it's also not certain that you give a person an Ambien, they're going to go to sleep either. Is that correct?
I believe that's correct, although I don't have a lot of experience administering Ambien.
But in the event that the person does go to sleep under either of those scenarios, you would expect to be able to rouse them verbally.
Yes.
And noise in the room would probably cause them to, you would expect, could potentially cause them to awaken also. Is that correct?
Correct.
So we're really talking about minimal sedation here, aren't we?
It's, my understanding based on the doses and medications that Dr. Murray administered, they would be in the range of minimal sedation.
And in that minimal sedation, the airway you'd expect to be unaffected?
Yes.
Ventilation would be spontaneous,
Yes.
and there should be no effect on the cardiovascular function.
Correct.
And in the event that the propofol were even present after a period of 5-10 minutes, you'd expect even that to be totally gone. Is that correct?
Correct.
Okay, lastly, doctor, we talked about, I want to show you, exhibit. It's quadruple R, Your Honor. It shows here the propofol level of 2.6 femoral concentration, meeting the femoral vein concentration of the lorazepam at 0.169. Is that still what you feel the most likely cause of death in this case?
Yes, I do. And I'd also point out that there actually is lidocaine present as well at that time, which you would expect to find because the final dose of fatal dose of propofol would have contained a mixture with lidocaine.
And that lidocaine level, is that traced by, you got to take my word for it, but it's a green little squiggly line that goes up, comes down, and it goes up right adjacent here to the propofol line. Is that the one you're talking about?
Yes, sir. I would expect they would follow very similar patterns.
And that lidocaine line that ends up here at 0.84 corresponds with the toxicology at time of autopsy?
Well, I didn't do the modeling myself, so it's just a guess, but I would expect it to be in that range.
Speculation, he says it's a guess.
The objection sustained. I didn't do the modeling myself is the answer. Everything thereafter is stricken. Thank you.
Is this, would this modeling be consistent with your knowledge of lidocaine and the blood concentrations received by respective doses?
It seems reasonable.
Thank you. Your Honor, that's nothing further at this time.
Mr. Flanagan, thank you. Recross-examination, Mr. Walgren?
No, I have no questions. Thank you, Your Honor.
Thank you. May Dr. White step down, subject to recall, Mr. Flanagan?
Yes, Your Honor.
Mr. Walgren?
Yes, Your Honor.
Dr. White, I want to thank you for your testimony. Sir, please don't discuss your testimony of the facts of the case with any other witness until we finish the trial. You may step down. However, you are to remain on call, and you're subject to recall. Thank you. May I see counsel, please? Oh, may I see? After a big 42 minutes, you take a mid-morning break, remembering, of course, all the admonishments, written and verbal. We have some other matters we have to discuss for a little bit. So please enjoy the break, and we'll buzz you out in a few. Thank you.